Right, thanks very much indeed. Welcome to everybody for this this webinar, which I've got to say is a little bit of a first for me. I've not actually presented a discussion like with the one that we're having this evening, and I'm really looking forward to it. Essentially, what this is hopefully going to be is an exploration of a career path that was taken by our colleague Will Loveday, who I met a couple of weeks ago at a GIC course, which Will was an active and successful member. And in conversation, we had the opportunity to explore some of the very interesting issues that he's experienced through the career development that he's had over the last few years or so. Among the things that I was particularly interested in was the fact that he had a story to tell that was possibly somewhat different and not typical, or certainly not as typical as I thought it would possibly be. And it reminded me of the enormous value of, from time to time, spending a little bit of time thinking about the nature of the experiences that we have through life. A number of years ago, I wrote my PhD thesis and constructed this on the basis of it being an autobiography, and came across some very interesting observations about the nature of our reflections on life experience. And among them were these that I just briefly want to share with you. So here's the first one from Sheridan in 1993. So a few seconds to read that. And that led me to recognizing the fact that in telling our stories, we sometimes recognize things about our experiences that we hadn't necessarily thought of before we started to actually tell the tale. And in some of the conversations I was having as I was developing my thesis was a conversation I had with a very experienced adult educator from the United States who said that he didn't know what he thought until he heard himself say it. And I think that reflects the importance and the significance of autobiography. So to return to our focus of tonight, and that is my colleague Will Loveday, who, as I said earlier, I met on a recent GIC. So, Will, if you'd just like to say a few words about who you are and where you're currently working, and just by way of an introduction.
Sure. My name is Will. I'm currently an F2 doctor working in clinical oncology at UHCW, which is a hospital in Coventry. So for those that don't know, an F2 is a doctor in their second year of after qualifying. We rotate around different specialties, kind of 4 months in each one. So this will be my fourth one that I'm in at the moment. Before that, I was a medical student, and before that, I was a paramedic.
Okay, and that's the focus really of where we're going to be heading in the next 40 minutes or so. So thinking about your experiences in the very earliest stages of your career choices, where could you talk us through and walk us through your sort of late secondary school experiences and into your first career choices that you were making as a late teenager?
Sure. I mean, kind of looking back, I think I really didn't have much idea about what I wanted to do in life. Going through kind of secondary school, I finished my GCSEs and just kind of picked subjects that I was interested in, which led me on to my A-levels, but I still didn't really know what I wanted to do. So that kind of lack of direction, I think, led to me dropping out of my A-levels and just kind of looking around and trying to take stock for a couple of years, trying to work out what I actually wanted. And it was just initially almost on a whim. And I think looking back to the person I was then, I don't think many people would have looked at that person and thought, you know, he would go on and make a anyway decent paramedic. But I think we kind of grow into the roles that we put ourselves in. So yeah, I did an access course and then did a BSc in paramedic science, and kind of went from there. And the reason really was just that I think it was my mum that just said, you know, you're a very calm person. you like driving and you quite like science, so maybe give it a shot. And it was just a throwaway comment like that, really, that got me there, and then ultimately to where I am tonight. Okay.
I mean, that you've just described quite quickly, really, three types of learning experiences: the very focused orientation towards a particular approach in secondary school, and then you mentioned access courses, and then subsequently an undergraduate degree program. And I wonder if you could share some of your thoughts about the way in which you experience those different educational settings, and how you as a learner were able to develop possibly the sorts of skills that we associated with the adult learner, perhaps, that you subsequently became.
Yeah, so I think at secondary school, I certainly hadn't made that leap to adult learner by that point when I was doing my A-levels. And I think that kind of reflected in the fact that I left and wasn't getting on well with it. And certainly looking back, when I was doing my access course, I actually had an end goal in mind, and was very much more driven to get there. I was not just learning because I had to learn, but I was learning because I wanted to, because I had a goal. And I think that was the kind of the biggest change really there for me.
Okay. And did you experience the teachers differently? I mean, were their attitudes and orientation towards the students and different in the access and undergraduate years to your experiences in school?
Yeah, again, I think they probably were. That it was very much in secondary school. Here is the information, here is the textbook, and we're going to teach you this information. Whereas on the access course and on my paramedic degree, it was very much, yes, there are lectures, and yes, these are the broad topics that we want you to cover, but you're going to have to go away and put some work in to make sure that you can cover these topics. So yeah, there was certainly a difference in teaching style. Yeah. There.
And during the period of your undergraduate studies, were you exposed to the practices of the paramedic community? I mean, were you out there on the ambulances and becoming a member of that community of practice?
Yeah, so that's one of the best parts, I think, of the paramedic courses, is that it's a combination of the academic side of things along with the kind of practicalities of being on placement and of doing the job that you're working towards. I think that helps a lot as well with giving you a target and kind of motivating you to get there, because you can directly see where you want to be.
Yeah.
And it was a good position to be trying to put the things into practice that you're learning about.
Yeah. Would you say that was the dominant learning environment, or was it the work that was going on in the classroom and your study and writing your assignments and so on? I'm very interested in this notion of the community of practice being the enabling characteristic of entry into any profession.
Yeah, so I think it was roughly kind of 60-40, with 60% of it in the classroom and about 40% of it on placement. My course was split up into placement blocks, although I know that other courses have it as a certain number of days per week that they would then be on placement. And it was always that kind of placement that I most look forward to. That's the reason why I was there.
Okay. Did you come across any sort of mismatch between the actual practicalities of life in the ambulance and in that community, as opposed to what was being talked about in the sort of more theoretical orientation, perhaps in the university?
Yeah, absolutely. I think many, if not most, or if not all, students will also kind of at some point think, why am I writing this essay about leadership? I just want to learn about the medications that I'm going to be using. I want to learn about the diseases and how I'm going to treat those. And I think a difficulty in at the time seeing the relevance, but I think a lot of those essays and kind of learning to write and to critically appraise ideas, although at first doesn't seem like it's going to be directly relevant to your practice, it actually is. When you're practicing and some new research comes out or a new guideline, actually it then does put you in a position that you're able to kind of critically appraise that and not just take it as it says, but to kind of look at it a little bit more closely.
Right. And I mean, did you experience any conflict between the practices and the theory at all at that stage of your career?
Yeah, I suppose I did. I think it's often very different how it's done in the classroom to how it's done on the road. And at times it kind of puts you in a bit of a slightly awkward position where you're thinking this is what we should be doing, and your mentor, the person that you're there watching do the job, is doing something different.
Sure.
So certainly, you wouldn't want to, unless you felt it was actively unsafe, talk about it with them in front of the patient. But it did lead to some interesting kind of conversations afterwards. And some clinicians able to justify, well, actually, yes, this is what we should be doing, but this is why I did this, and others less able to. But
sure. Yeah. And was that a fairly common conversation, really, as part of your downtime or travel to case time, that type of issue?
Yeah, I guess so. When you're stuck in a cab with someone for 12 hours, you talk about a lot of things, but certainly that would come up often. And I mean, it was what I was doing with my life. It was learning the profession. And that was what I was focused on. So yeah, I think I probably talked about that quite a lot, maybe more than other students. I don't know. Yeah.
Okay. So you graduated how many years ago?
I think about 7 years ago from paramedic science.
Okay. So how was that induction into life as a fully qualified paramedic? I mean, what was your experience in that next few years or so?
So it was actually a pretty smooth transition, which I think is in large part due to the course that I was on. And I think I'm a big fan of the way that you start off, and you at first maybe you're just watching, as your mentors work, and then maybe next you'll kind of work up to, and you'll go in first, and you'll say, hi, we're from the ambulance service, how can we help? And then kind of come to a stuttering halt when you realize that you don't know anything, and then kind of step back. But you gradually move forwards. You'll be taking the physical observations, you'll be doing the assessment. Maybe towards kind of second, third year, you're then coming up with your diagnoses, your management plan. So it just felt very smooth, really. By my third year, I was doing the job essentially that I would be when I qualified, just with someone watching me and giving me useful feedback after each job, after each patient.
Sure.
So it actually felt very smooth. Right.
And was that feedback an important part of the process of your sort of, if you like, induction into the community as a large?
Yeah, I think it was. I think, again, one of the best parts of my course was that to a large extent we were able to choose who we spent our time with on placements. Okay. And I guess it's one of those where you pick someone that works how you would like to work, and that you kind of look up to and respect, and think clinically they're very good. So actually, just by virtue of working with them, any feedback from that person is very well received, very useful.
Yeah. So there must have been a point in your sort of paramedic career that you decided that you were going to think about heading off in a different career direction. I mean, what sort of things were motivating you at that point to make that fairly significant extra step in terms of your education?
So I really enjoy learning kind of new information, and I think I've learned about myself that although I might be working towards the goal of being a paramedic, actually when I get somewhere, I kind of feel, and I think a lot of people probably do, that I want to keep moving forwards. I don't like to stand still. I like to kind of constantly moving forwards and working towards something. And I think although there are opportunities to do that within the paramedic profession, questions kind of come up about how far am I going to be able to go? And although it's constantly developing, and the scope of practice of those kind of more specialized roles is expanding, how much will they expand, and will I spend another few years getting to that point? And then thinking it's still not enough for me, I still want to move on and do more. But it was certainly it was a difficult decision. But yeah, I was kind of looking forward, wanting to learn more and to work in different settings as well. So one of the main areas that paramedics tend to move on and progress to will be either management or working in more kind of primary care settings, maybe GP surgeries, urgent care centres, that kind of thing. Kind of a less acute side of things, or as more of a critical care paramedic. That was kind of more of the direction that I was interested in going in, but that role in itself was more competitive to go for. Okay. So I knew that if I was going to go for that, I'd probably need a couple more years of experience, and I may or may not get it at that point. And then it was just kind of looking down the line, and kind of time was passing me by, and I think I was just getting, just keen to progress and move on, and I felt like I was standing still.
Yeah. Okay. So that was the product of a series of events or repositionings in terms of your attitude towards the nature of your experiences at that time. I mean, there's a very interesting theory in adult education called transformative adult education, and there's a discussion as to whether that's the product of a significant event or the product of a series of things over a period of time. And what you seem to be describing is the latter rather than the former. It wasn't an epochal event. It was a succession of things that perhaps impacted on the way in which you saw a future emerging, would you say?
Yeah, I think that is probably right. And I think that there were lots of factors that I was dissatisfied in some ways with my role at the time. Some of those, were likely to change. Some of those were unlikely to change, and some of those were certainly not going to change. So there were certainly a lot of factors there. I think at the time, the biggest factor really that led to that decision was, I think, unless you're careful, unless you're very motivated, working in the ambulance service, you risk not getting the direct feedback on your clinical decisions that you do in other areas of healthcare. Okay. So, you might decide to leave a patient at home, and you might never find out whether that was the right decision to do that or not. Okay. You might have another crew come up to you later that night and say, "Oh, by the way, that patient you left at home, we had to rush them into hospital. They were really poorly. I think you missed something there." And so you might kind of get that. But actually, the vast majority of patients that you leave at home, you wouldn't know about. And likewise, if you decide to take them to hospital, you may well get the impression handing over that whoever you're handing over to doesn't think they should be there at the hospital. But that doesn't mean that it was right or wrong. But actually, you rarely know what the final diagnosis ended up being, what the treatment was for that, how long they stayed in hospital, were they admitted. So I think it's not entirely fair to say that, well, it's not fair to say that you get the same year of experience over and over as a paramedic, but I think unless you're very motivated and keen to kind of keep adding and learning and looking outside of your immediate 9-to-5 job, I think you risk not progressing as much as somebody that was working in a hospital, for example. Okay. So,
I mean, the situation that you've described about not knowing the outcomes of the decisions that you made, I mean, it's potentially quite a challenge, isn't it, really? And can you imagine a situation where that is something that could be resolved? I mean, is the capacity within a system, either by virtue of recording or some sort of engagement with, future carers, that issue could be addressed before?
I think it could. I think that's possibly one of the things that frustrated me about it, is that, I could see ways that you could solve this as a problem. It'd be a big piece of work, and as far as I'm aware, that piece of work hasn't been done yet. But for example, looking at patients going into hospital, you could have a few hours set aside each month with someone dedicated from the hospital, someone clinical at the hospital that can then talk through, you can select some patients in advance that you're particularly interested in, and could talk through their journey in the hospital, talk through the blood results that they got initially, talk through the scan results, the diagnosis, right, the management. And I think that, yes, there's certainly a time cost there, and certainly a financial cost as well, taking these people from a clinical role to be kind of purely having that discussion. But I think all you'd have to do really is to show that improved some outcome, whether it's kind of clinician confidence in their decision as to whether to take people to hospital or leave them at home, and suddenly you can see that that's saving money, that's saving time, and becomes easier to justify. And I guess similar for leaving at home, but just through primary care, through the GPs.
Sure. It would be interesting to hear colleagues' views on that. If people have got thoughts about that particular suggestion, I think it sounds very interesting. So you started your medical studies as a graduate entry at the University of Warwick, but continued with your paramedic work, I understand. So say a little bit more about how those two experiences came together in any significant way.
Yeah, so I really enjoyed my time as a paramedic, despite kind of leaving that as a full-time profession. And I was very keen to kind of keep my skills and my knowledge up in that setting, in the pre-hospital setting, as much as I could. That was certainly very important to me. I think also, certainly there was a financial element to it. It's difficult going from a full-time job where you're earning money and you're paying rent to suddenly being a student just reliant on student loans. And actually doing the graduate course meant that the student loans that I was eligible for weren't quite enough on their own to kind of fully support me. So there was certainly a financial element there as well. But I think as a paramedic, being a paramedic, that formed part of my identity by that point. So I was keen not to lose touch with that.
Okay. And how did your paramedic colleagues, and possibly more interestingly, your fellow medical students react to the sort of the nature of the experiences that you were able to draw on in seminar discussions and so on?
Yeah, so my kind of pre-hospital colleagues, I think, were generally pretty understanding of it. I think, in conversations I had then and have had since, it's become apparent that there's probably quite a lot of people that are considering a similar move,
right.
To varying degrees. So there was a lot of interest, and a lot of people asking the question, why did you do it? And, agreeing with the reasons that I was giving, and saying that they were thinking of doing similar. A lot of people also said something which I think is interesting to talk about, if only because so many people said it, and that is, a lot of people said, you must be very clever, there's no way that I could do that. And every time I don't think that is true. If there's anyone listening tonight or over the next few days watching this recording that kind of is feeling that, I'd encourage them to really look at that. Having gone through it, I don't think that is the case. I think if you're able to to work as a paramedic and to get to that point, you can go on and become a doctor if that's what you want to do. There's a lot more information, so there's a large quantity of it, and it's you need to be quite motivated to put time in to learn that. But actually the concepts themselves are not that much more difficult than or that different really from what you learn on your paramedic degree.
And your experiences of talking to fellow students, I mean, how did they react to your having that pool of prior experience as a paramedic to draw on, in terms of the way in which you contributed to discussions about both clinical and perhaps non-technical skills related issues?
So yeah, that was also interesting. I was keen not to certainly try anyway, not to monopolize discussions. So it was interesting. We're all starting from different points, particularly on that Warwick degree. Many of the graduate medicine degrees need you to have certain previous degrees. They might have a short list of previous degrees that they'll accept, whereas Warwick would accept any previous degree. It didn't have to be relevant at all to that specialty. So I think a lot of people had lots of different things to bring to the table. There were people that had done history before, that had done Chinese language, that had done maths, economics, you name it, they'd done it. So that also meant that having, spent, I worked as a paramedic for 2 years after I qualified. So that, kind of a total of 5 years working in that area. I think that time would have been perhaps not very well spent if I wasn't better and more well informed at dealing with emergency situations, and had maybe a higher baseline than people that hadn't had any clinical exposure before. So it's certainly useful. It certainly helped with those things. But those kind of seminars that you mentioned, we had that as a form of kind of case-based learning, case-based discussion.
Yeah.
And a lot of the focus there, again, talking of adult learning, is on, here is the little vignette, here is the case. And as a group, we want you to go away and learn about this and look at reputable sources and learn how to learn. So I was very keen not to just give people the answers at that point.
Sure.
But it certainly has been very helpful. One of the big things that I find being a paramedic teaches you that medicine doesn't teach you is medicine doesn't teach you to make decisions. It'll teach you the background, it'll teach you the pathophysiology, it'll teach you the medication, but it doesn't teach you to stand there having assessed the patient and make a decision, which paramedic certainly did. So I think that was probably one of the biggest things that I brought with me.
Right. Would you say that's the nature of the sort of apprenticeship model that junior doctors go into through their foundation years and then subsequent specialty training?
So I think it is. I think a lot of the foundation years of when you're a junior doctor is learning to make decisions, to kind of assimilate information, to kind of come up with a diagnosis or a plan, and to be able to justify that. Because medicine, healthcare generally it's a big area where there's it's not just black and white, it's mostly shades of grey. And as long as what you're doing is reasonable, as long as you can justify it and why you're doing that and why you're not doing something else,
sure,
that's kind of okay. So yeah, I think a lot of the foundation years is people learning that and learning to have confidence in themselves and to make decisions. Yeah.
I mean, it certainly is possibly the more challenging situation, because the consequences of getting it wrong are fairly profound, aren't they? And you have to deal with them, not only with the patients, but possibly with their families and so on. So it is very serious type issues, really. So you graduated now 2 years ago as a doctor, and you're coming to the end of your foundation year, is that right?
So it was about kind of 18 months ago or so I graduated, yeah, and I'm about halfway through my just over halfway through, I think, halfway through my second year of foundation.
Yeah.
And at the end of that, then it would be looking at probably going to specialty training.
Okay, so in terms of your current experiences as a junior doctor, currently working in a particular department, but having been in other areas, I mean, what's your impression of the major differences between your role now as a doctor as opposed to your more frontline experiences as a paramedic? Yeah,
so I think the thing that affects me most and that I kind of have reflected most about, the main difference, and it's going to sound really simple, but it is just that as a paramedic, generally you're responsible for one, maybe two, sometimes maybe in rare circumstances a few patients, but generally just one patient at a time.
Yeah.
Whereas the other night in the hospital I was responsible for like 8 wards of each with kind of 30 to 40 patients on. So inevitably there's less time that you can spend per patient, and unfortunately I think what I've learned about myself really kind of going from paramedic to doctor is that I really miss that one-on-one time with the patient, and a lot of the pleasure that I get out of the job is by doing a really, really good job for that one person.
Sure.
And unfortunately in the kind of ward environment, you can't really give that same level of care to everyone that you'd like to. So you've got to kind of learn to split your time between the patients and learn, yes, I could do more for this patient, but if I do, it's going to mean taking me away from this other patient.
Sure.
And actually, sometimes, I might see one of the patients on the ward. I'd speak to them all as I'm doing the ward round, but I might only speak to them for 20 seconds out of the day. That would be it for my face-to-face time with that patient. And I found that quite difficult, going from that, going from as a paramedic, you see them for sometimes hours.
Sure. That is quite a significant change, isn't it, really, from the close attention to an individual, perhaps, rather than those numbers. I've got to say, I hadn't appreciated the numbers of patients that you might be involved in at any one time. Presumably, though, that diminishes as you make progress through your levels of seniority, and you get more closely involved with individual patients as you specialise. Is that true?
It can be true.
Yeah.
It depends on what specialty you go for. I'm looking at going to anaesthetics, which so it certainly would be the case for that. That's one of the main draws of anaesthetics for me, is that it's just back to generally one patient at a time, doing everything for that one patient for as long as they need you, and then kind of moving on to the next patient, handing your first patient over, moving on.
Sure.
And then having your kind of full attention on that next patient. So that certainly appeals. Other specialties, you would have potentially more patients that you would be responsible for, kind of as you move up in seniority, but kind of more indirectly responsible.
Sure.
You might be responsible for supervising, lots of doctors, looking after lots of patients.
Yeah, in ED, for example.
Exactly. Yeah.
Okay. In terms of the nature of the community that you become part of, have you noticed any particular differences between the community of practice that was paramedicine and the community of practice that is medical, or whatever, however you describe your particular community of doctors?
Certainly, I think the first thing that comes to mind is more hierarchical. There's certainly a much greater focus on hierarchy in medicine, which for the most part was it was a fairly flat hierarchy in the pre-hospital setting. In the ambulance service, you work very closely with your crewmates if you're on a dual-manned ambulance, and you both take turns driving, you both take turns in the back with the patient, and occasionally if the patient is sick enough, you may have to go into the back yourself over your colleague, but essentially you're both doing the same job.
Sure.
If the patients have been lying on the floor for ages and have defecated everywhere, you're both going to clean that up yourself. You're both doing the same job. Whereas in hospital, it is very different. The different types of job role there, for example, even from the cleaners, a lot of people just kind of tend to completely blank them, and it's certainly not the norm, but I have been shocked a few times at people being quite rude to cleaners and kind of domestic staff. But even kind of beyond that, into the kind of clinical staff, into the healthcare assistants, into the nurses, the physiotherapists, occupational therapy. There's obviously a huge number of different staff in a hospital, and it feels like a big kind of disconnect between doctors and a lot of the other specialties, or a lot of the other roles there, but also within that kind of group of doctors, there's a lot of hierarchy there.
Sure.
Your consultants are often treated with this kind of level of, or expected to be treated with this level of kind of complete deference and questioning obedience at times, which really seems quite kind of antiquated in today's NHS. And that's varying degrees depending on the specialty, the hospital, the consultant. But I'm a big fan, for example, of just speaking to people on a first name basis. I would rarely introduce myself to a patient or a colleague as Dr. Loveday. I'd just say, hi, my name's Will. And I feel if I'm going to do that and then say to a patient, you know, hi John, for example, you know, I'm Dr. Loveday, I feel it's kind of putting up a barrier there.
Sure.
And so I'd always introduce myself by a first name basis, but a lot of the consultants would always insist on, you know, giving their full Dr. So-and-so. So I feel that kind of puts up barriers as well.
Sure.
And actually I've witnessed a few times some very junior doctors, unfortunately brought to tears by, you know, some very harsh words in a public setting from some of their seniors. So there certainly is a lot of work to be done still to kind of help with that.
There does seem to be a movement in a more flattened hierarchy in some communities, doesn't there? I'm conscious of through the work I've been involved in with things like life support courses, most noticeably probably things like the European trauma course, where, you know, there is a deliberate approach, you know, a team approach to management, and almost by definition the team has got a flatter hierarchy, even though issues around leadership are still important things. So, I mean, do you sense any change in this particular issue? Do you think it is improving as a consequence of people's greater awareness about, you know, team dynamics and so on?
Yeah, I think we've certainly come a long way from where we were before, and I think, you know, certain areas, as you said, have come even further. You tend to see when you approach that kind of environment, if you're going to be on the cardiac arrest team, for example, in the hospital that day or that night, you know, it's a much flatter hierarchy there. Everyone introduces themselves on a first name basis. So I think in those kind of more emergency settings, and probably the settings that are taking prompts from those resus council courses, from the European trauma courses, in those settings, things are improving. So I think it's only a matter of time until that filters out further.
Yeah, yeah. So you've 2 years in, or almost. Where do you see your career heading? You mentioned that you're likely to be thinking of anaesthetics as a likely specialty, but where do you see the specifics, perhaps?
Yeah, so certainly I would like to kind of get more involved in anaesthetics, that one-to-one patient contact, the closely working with patients' physiology, and seeing that direct feedback from the medication that you're giving them, treating some very unwell patients and keeping them kind of stable throughout. So I think that's kind of certainly moving towards that. I'd also like to keep working pre-hospitally, and that's certainly a large part of my professional life that I'd be keen not to lose. Right. So whether that would be looking at something like PHEMS, whether that would be doing some more shifts just on ambulances. In fact, over the next few weeks, I've got some shifts that I'm looking at working as a paramedic.
Okay.
So I'm keen to kind of keep that aspect. I'm also keen to kind of get into education. Okay. I've kind of learned again that about myself, but I really enjoy you know, teaching things, and having gone through that process myself, I can see areas where things weren't taught well, or where things, you know, people haven't explained things very clearly, and I think I found that I'm generally quite good at explaining things clearly like that. So I think you know, I enjoy that and would be keen to kind of get more involved with that, and if possible to try and work on solving that problem pre-hospitally, and getting more education out pre-hospitally.
So ALS and similar types of courses then are part of your career development opportunities perhaps into the future? Yeah,
absolutely. It's even before being put forward to be an ALS instructor, it was certainly simulation, and particularly high fidelity simulation with a kind of focus on human factors and kind of cognitive bandwidth was something I was very interested in. Yeah. And a kind of a direction I was keen to explore.
Yeah, and certainly most of the life support courses are often people's first introductions into direct involvement or more direct involvement in medical education. And I think that is one of their great positive benefits to the community as a whole. Among the things that I'm very interested in is the nature of people's life experiences as you described them in the last 40 minutes or so. And I'm just wondering if we can just sort of switch focus for the last observation really from you, that has the process of preparing for and thinking through this evening's webinar impacted on you in any way in terms of your own thought processes about the nature of your educational experiences so far and your, the career opportunities that are going to arise from that?
Yeah, I think it has. I think it's caused me to kind of reflect back on where I've come from, and I don't think I've realised, remembering back to the shaggy-haired A-level dropout that I was, with no kind of real drive and no idea what I wanted to do. At one point, I remember clearly saying to my parents, who were not best pleased, but saying, I think all I'd really like is maybe just to work in a shop 9 to 5 and have a flat above it, and just have my evenings to myself and just live an easy, stress-free life. And I think I'm very far from that now.
Yeah, indeed.
So I think, on reflection, seeing where I was has been really interesting. I think I don't think I could have gone directly from where I was to medicine and to where I am now. Certainly, I think, although people sometimes ask me, do you regret doing the paramedic degree? Do you regret kind of going down that route? Do you wish you'd just gone for medicine? And actually, no. I think it was a journey, and I think if I hadn't gone on that journey, I wouldn't be where I am today. And I think not only that, but I think I wouldn't be the doctor that I am today for having gone on that journey.
I generally share that view based on my own experiences of not entirely dissimilar sorts of hesitant pathways, perhaps, in terms of a route through education, and a recognition perhaps that we continue to engage with that throughout our lives, having had this lack of certainty and possible sense of direction in the early years. It's almost a byproduct of having had that sort of slight interruption, other than starting in the formal system as a 5-year-old and emerging 23 years or so down the line without ever really having thought about the nature of the process. So thanks very much indeed for that, Will. And if I'd like to hand back to Andrew to see whether we can pick up any questions or comments or observations that have been made during the course of our discussions. So over to you, Andrew.